It is on HPTN 065, a qualitative substudy of HPTN 065 that is, and the webinar is titled The Acceptability of Financial Incentives for Viral Suppression. It will be led by Teresa Gamble and Elizabeth Green, and we will also have Wafa El-Sadar join us today to answer questions at the end of the webinar. Teresa, I believe you're already on the call.
I am. So, Greg, I really want to thank you and Hank for inviting us to give this presentation today. This is a qualitative substudy that was done for a parent study in the HPTN called HPTN 065. This was an opportunity for us to explore some additional information for this study, and we're going to be reviewing data today in today's presentation. Next slide. So this is the agenda for the presentation we're going to make today. Because our results are really related to the study, we're going to spend a little bit of time at the beginning talking about the design of HPTN 065 and its primary results for the viral suppression component. These results were presented at CROI this year. And then we're going to spend some time talking about the rationale behind it, the methods, the results, and then we'll have time at the end for Q&A. Next slide. So the overall purpose for the parent study, HPTN 065, was to determine if you could conduct and treat approach to HIV prevention at a community level. Next slide. So this diagram here really shows what the test treat approach is to HIV prevention. If you start by looking at the left of the slide, you have an entire population in a community. Some are positive, some are negative, and you want to encourage them to test so that you can find out everyone's status. In the middle of the slide, what you see is once people determine their HIV status, they can receive counseling, regardless of whether they're positive or negative, and change their behaviors to either prevent transmission or acquisition of HIV. For someone who's positive, you want to link them to care. That's what LCC stands for. And at the care sites that they enter, you want to engage them in care, keep them in care, start them on ART to the point where they are taking the medication regularly and achieve viral suppression. We then, in that situation, have a biological control over HIV transmission, because we've shown in other HPTN studies that if you have a suppressed viral load, your probability of transmitting it to someone else is very low. So you really have modes to decrease HIV transmission in a community overall. Next slide. So HPTN 065, the parent really had multiple study components that mirrored all these different pieces of the test and treat approach. But what we're going to talk about today is just the component used to encourage people to receive and maintain viral suppression by using a financial incentive. Next slide. So HPTN 065 was conducted at 2 intervention cities in the U.S. The first one was Washington, D.C. We had 19 HIV care sites participate in that venue. And we also had 20 HIV care sites participating in the Bronx, New York. Within these 2 communities, we actually randomized care sites to either give out a financial incentive to encourage viral suppression, or they could do whatever they were normally doing for their standard of care to support adherence. One important thing that we want you guys to be aware of that was part of the parent study is that all patients at the financial incentive sites could participate in the intervention. Right, can you hear that there's an echo? Oh.
Yeah, I just muted that person.
Got it. Thank you. So what that means is anyone who was on ART at the sites could participate in the program. It didn't matter if they were just initiating ART or if they had been on ART for a long time and were struggling, or were on it and had actually achieved viral suppression in the past. So everybody at that site that was randomized in F5 participated.
The file cabinet at the top.
Next slide.
The one on your right-hand side.
If you're on the webinar, would you please mute your line? It is *6 to mute yourself. Thank you.
So what you see in this slide is an example scenario of how the financial incentives were given out for viral suppression. So what you sort of see in this arrow over time is a person who has come to an HIV care site and has been engaged there for a while. We measured engagement at the beginning by saying, do you have a viral load in the last 3 to 9 months? And in this particular scenario, it's someone who's just initiating ART. So in January, they have a viral load drawn and they start ART, but they can't get a card because they haven't had time yet for the ART to lead to viral suppression. But 3 months later, in April, they come back. They do have a suppressed viral load, so they can now earn their $70 gift card. In July, either they don't show up or their viral load is no longer suppressed, so they can't get a card. But in October, they come again, and once again, they're virally suppressed, and so they earn another card. And over the course of the 2-year intervention, someone could earn up to a maximum of 9 gift cards. Next slide. One thing that's also important to know about 065, and in particular this component, is that we did not collect any individual data on people. We used HIV surveillance data to look at the outcomes of the study. So in the pictorial part of this diagram, you see that there's information going from the care sites via their labs, because this is automatically reported to the surveillance system, on CD4 and viral load that went to the local health departments and then on to the CDC. And that data then was sent to our database in aggregate. So we could see, for example, the percentage of people who were suppressed at a site, but we couldn't look at an individual person and say, oh, they had X number of viral loads over the course of the intervention. These are the times that they were suppressed. These are the times they weren't. The outcomes of the study were measured in 3 different ways. The primary endpoint was viral suppression overall at a site. And so we basically looked at the people who were engaged in care. Those were people who had at least a couple of CD4 viral loads in the last 15 months. And then we looked at the percentage of people who were suppressed at that site and then compared the financial incentive sites to the standard of care sites. We also looked at viral suppression at the peak of the intervention. This was the last quarter of the study, and it allowed time for the intervention to really be optimized. So that means both implementation at the site as well as time for it to work on any individual patient. And then finally, we looked at a measurement called continuity of care, which is really looking at the number of CD4 viral load measurements as a proxy for visits. So we were looking to see if the fact that this financial incentive was there could drive up the number of visits. So now I'm going to just have a few slides on the overall results. So nearly 40,000 gift cards were dispensed to more than 9,000 patients over the 2-year program at these 19 sites that were randomized to offer FIs. Half of them were in the Bronx and half were in DC. And overall, no significant increase was seen in viral load suppression as a percentage of the patients at the clinic. But we did see an effect on some subpopulation of our sites. For example, we saw that the proportion of patients with an undetectable viral load was 5% higher at hospital-based clinics. And at clinics where fewer patients were suppressed at the beginning of the study, we had a 10% increase in the percentage of people virally suppressed comparing the FIs to the standard of care sites. Next slide.
Oh, okay.
If you look at the peak of intervention, so this is the last quarter, we actually saw a 5% increase overall when we were comparing the financial to the standard of care sites. And these were higher increases when we looked at some special subpopulations. So for example, at smaller care clinics, 11% more people were virally suppressed at the peak of the intervention. That's the last quarter. And at sites where people started off with fewer people having an undetected viral load, there was a 13% increase in the percentage of patients who achieved that goal. Next slide. And then finally, we looked at continuity of care. This is really looking at how many people came back for visits to have blood drawn for viral load and CD4. And overall, we saw an 8% increase. And depending on how what subsets of the sites we saw an increase either from as low as 7% at hospital sites all the way up to almost 20% at smaller care clinics. So we saw quite an impact on the the volume of visits that people came and received during this intervention. Next slide. So now I'm going to turn the presentation over to Liz to talk about the methodology and the first couple of results that we got, and then I'll continue and end the presentation.
Okay, so as Teresa said, I'm now going to focus on the qualitative sub-study that we conducted. So as we were implementing the HPTN 065, what I'll often refer to as a parent study, we started to hear a lot of anecdotal stories about the experiences and reactions and issues that people were having with the FI intervention. And some of these were expected, but some were not. But we started to wonder, what were the range of experiences people were having with the FI? So as Teresa just described, we weren't actually collecting individual data for the 065 study. So by undertaking the qualitative sub-study, we set out to really systematically collect information about more individual experiences and attitudes related to the financial incentive in this study. The size of the financial incentive intervention also represented the largest study to date of a financial incentive intervention for viral suppression. So as Teresa noted, with almost 40,000 gift cards dispersed to over 9,000 patients. So we really also recognized an opportunity here to qualitatively explore how this was implemented, how acceptable it was, and what impact it may have had on medication-related motivators and barriers. Next slide, please. So we collected qualitative data from 3 different participant groups, and those were patients, investigators, and staff. For patients, our goal was really to have a diverse sample so that we could explore the range of experiences. In order to do this, we used a purposive heterogeneous sampling strategy where we had 5 predetermined subcategories of different types of patients that were based on ART and viral suppression status before and during the study, and I'll go over those a little bit more later. And we asked sites to recruit within those categories. We then conducted in-depth semi-structured interviews with patients, and those interviews were conducted by qualitatively trained interviewers who were external to the study team, and those were in-person interviews. In order to be eligible for an interview, patients had to have been eligible for the financial incentive for at least 15 of the 24-month intervention, and had to currently be in care at one of our FI sites. For investigators, our goal here was really to have more of a broad sample, so we actually emailed all of the investigators who oversaw the study for at least 12 months of the 24-month intervention and invited them to participate in an interview. And these interviews were done over the phone by a qualitatively trained PhD level member of our protocol team. And the vast majority of the investigators were physicians. Likewise, for staff, our goal was to have a broad sample, so we also emailed all staff who had been involved in implementation of the FI intervention for at least 12 months. Staff members had roles such as research coordinators, nurses, nurse practitioners, and physician assistants, but we intentionally excluded physicians, and this is because we conducted focus groups with staff, and we were worried that physicians might disrupt the dynamic of the group. And the focus groups were conducted in person by qualitatively trained moderators who were external to the study team. The bottom of the slide shows a timeline of both the parent study and the sub-study. So as you can see, the financial incentive intervention was conducted between 2011 and 2013. And qualitative sub-study data were collected after that intervention had ended, but before the HPTN 065 study results were analyzed or released. And this timing was intentional, as we did not want the outcome of the study to bias participants' retrospective opinions or recollections of their experiences with the intervention. Next slide. So we explored several different themes in our qualitative interviews and focus groups, such as feelings about the concept of basically paying people for viral suppression, what the various experiences were in giving or receiving financial incentives, post-intervention opinions related to the removal of the financial incentive, understanding of viral load, HIV medication adherence motivators and barriers, impact of the financial incentive on the patient, and the community awareness and site migration. As I said before, I'm going to just be talking about themes related to acceptability, which are these top 3 highlighted themes today. So all the interviews and focus groups were transcribed and analyzed in vivo, and we used an iterative synthetic content analysis and developed detailed memos and matrices in order to compare and contrast the sub-themes and themes across the 3 participant groups. Next slide. For the results, I just want to quickly say that we did present 4 posters related to this, showing the qualitative substudy findings at the recent HIV R4P conference, and those are referenced on this slide. We do have a draft manuscript on the acceptability of FIs for viral suppression, which is in process, and we also are in the process of developing a manuscript on medication adherence. Next slide. So this slide provides a summary of the data that we collected for the qualitative substudy. As we noted before, there were a total of 19 sites that were randomized to the FI intervention as part of the 065 parent study. For the qualitative substudy, we were able to interview 72 patients from 14 different sites. And so for the few sites that we were not able to sample patients from, that was mainly because they weren't able to get IRB approval within the time frame that we needed to collect the data. In terms of investigators, we interviewed a total of 12 investigators from 14 different sites, and those numbers are different because there are a couple investigators who represented more than one site. And we also conducted 3 focus groups with a total of 12 staff members who represented 10 sites. Next slide. This table shows a summary of the characteristics of patients that we interviewed. So just to summarize, our sample was mostly male, older, over 45 years of age, Black, non-Hispanic, and heterosexual. The majority had a high school education or less, and it was a very low income sample with over 3/4 reporting an annual income of less than $20,000. I do want to note that while we weren't going for representativeness, the demographics of the sample are pretty much in line with the population of patients who were established in care at these sites according to the surveillance data. Next slide. So earlier I mentioned that we had these 5 predetermined subcategories to drive our recruitment in order to get the diverse sample that we wanted, and this table presents sort of how that played out. I also want to note that we did collect viral load data for these patients along with their gift card log from during the 065 parent study in order to categorize them. Some patients did end up being recruited who we either were not able to collect all of the needed data on or who maybe didn't exactly fit one of our subcategories, but we still did include them in this analysis as long as they were eligible for the substudy based on the inclusion criteria. And again, that's because we just were going for a variety in our sample. So just to summarize this, most participants had been on ART prior to the start of the parent study, and most had received 5 or more gift cards during the course of the study, meaning that they were able to achieve and maintain viral suppression during the study. We also know from the surveillance data that this is pretty in line with the patient population of most of the clinics that participated in the study. But like I said, we were going for diversity, and so I think you can see line number 2. There was one subcategory that proved to be very difficult to enroll, but despite that, I think we did achieve a varied sample. Next slide. Okay, so now I'm going to present the results related to acceptability. Generally speaking, patients overall had a very positive opinion of the intervention, and investigators and staff also had positive opinions, but were a little bit more mixed, mostly related to implementation challenges. We identified 5 main factors that influenced acceptability across all of the participant groups, and those were emotional benefits, financial benefits, health-related benefits, philosophical concern about the use of financial incentives, and implementation issues. And we also explored acceptability related to the removal of the FI. So we'll be going through each of these now. Next slide. So by far, the most common reasons noted among all of the participant groups for liking the intervention were related to emotional benefits. Patients described that the FI intervention made them feel good, encouraged, appreciated, cared for. It was something to look forward to, and some even noted that it counteracted the negative feelings that they had associated with their HIV status. Next slide. So this patient really sums up this sentiment as he says that, really most of all, it makes you feel like someone cares. For investigators and staff, the emotional benefits were in the form of positive patient interactions. They noted improved clinic morale, and they noted feeling really good about being able to provide positive reinforcement to patients or to help those who were in need. Next slide. So this particular staff member recalls patients coming to them with a smile on their face because they got a gift card and could then afford something they needed. And this made that staff member feel good. We did ask investigators if they would be willing to implement the financial incentive intervention again in the future, and the majority did express a desire to continue implementing this intervention. But what was most surprising to us was that a couple of investigators actually said that they would want to do so regardless of whether or not the incentive was effective. Next slide. So you can see from this quote, and I'll just give you a second to read through it, this investigator says that their primary reason for wanting to do the FI intervention, again, was to be able to provide that system of positive reinforcement, even if it doesn't fully work. Next slide. Unsurprisingly, patients described the financial benefit as a main reason why they liked the intervention. Patients who said this fell into one of two categories. Either the financial incentive helped them meet a real financial need, or they really enjoyed the extra money as a special treat. The distribution between these two groups was pretty similar, though perhaps a few more in the financial need camp. Next slide. So these are two quotes demonstrating each of these sentiments. In the top quote, this man describes being on a fixed income and using the financial incentive for things like stuff for his house, food, and medications. The bottom quote, this woman describes being able to buy an outfit to make herself feel good. In designing this study, we weren't sure about what the amount of the incentive should really be. There were many conflicting opinions and much debate. Ultimately, in consultation with our community working group, we eventually decided upon the $70 amount. But we were still sort of unsure if it would ultimately be a meaningful amount to patients. And what these findings tell us is that indeed the $70 did seem to be a meaningful amount of money to the majority of patients. A few did say they could use more, and a couple actually thought it was too high, but overall it did seem to be a meaningful amount. And this quote sort of demonstrates, this participant says quite clearly that, I don't think $25 would be enough to change behavior, but $70 was very generous. This financial benefit that was seen by many patients was not always a good thing as experienced by some staff members. Specifically, some staff reported that the financial benefit seemed to supersede any other visit priorities, and for a minority of patients. These staff described patients who really lost sight of the intent of the financial incentive and became overly concerned with receiving the money, sometimes to the point of aggressiveness. I do want to stress that this did seem to be a minority of patients, and this was not commonly observed by investigators. But despite this negative aspect, most of the staff still had overall positive opinions of the intervention. Next slide. So this staff member demonstrates this by saying, while they had a positive experience, they really disliked the patients who felt entitled to get the gift card. And this word entitled was actually used by several staff members who described this sort of phenomenon. Patients who just wanted the money and were very rude about it. some patients, investigators, and staff noted that the perceived or experienced effectiveness of a financial incentive in changing health behaviors did actually also influence their acceptability of it. Next slide. So I do want to note also that many patients who talked about this as a reason why they liked the intervention often had a tendency to speak in general terms or to reflect that the health benefits could be beneficial for others as well. This patient says sort of generally that he liked the FI because it was an incentive to take your drugs and keep your viral load undetectable. And this extra incentive to him seemed positive. So interestingly, the perceived or observed health benefits were not only limited to the intended benefit, which was viral suppression, but were actually more commonly described more broadly and included things like general healthcare engagement and visit adherence. Next slide. So this investigator describes providers at his practice really liking the intervention because they saw patients adhering to care. They saw patients who were more interested in their results, and to a certain extent, they saw patients taking their medication better. So these are sort of things that they observed seeing, and the adherence to care and the interest in results was pretty primary for this investigator. Next slide. We asked participants how they felt about the use of financial incentives for viral suppression, and what we observed on all of the groups was what we a philosophical conflict about paying people to maintain a low viral load. And this is where many people saw benefits in the financial incentive intervention or described really enjoying it, but still felt that one should not need an incentive to take life-saving medication. A couple of patients completely disagreed with the concept of financial incentives for viral suppression, but actually no investigators or staff expressed complete disagreement, though a couple investigators did describe being resistant at first, but then coming to really embrace the intervention after it started and benefits were observed. Next slide. So here's a couple quotes to demonstrate this. The first quote, a patient pretty much says straightforwardly that an FI should not be a bribe to do the right thing for your own health, but then also says, well, maybe it could be helpful for some people, so it could be a good thing. Likewise, the staff member at the bottom here describes the financial incentive as being helpful, but then goes on to say that you shouldn't get a reward for doing what you're supposed to do. Okay, I'm going to turn it back over to Teresa to finish presenting the results.
So the first thing that I'm going to talk about is some of the results that we saw around implementation issues. And one of the places that we actually saw a lot of mixed opinions from both investigators and the staff was about the fact that there were increased number of visits. So if you remember back to the beginning of the talk, patients could receive financial incentives, gift cards on a quarterly basis. This was not mandatory for the study, so we didn't require patients to come in on a quarterly basis, but we wanted physicians and staff to be able to use it at least as frequently as the guidelines suggested. So what the guidelines in the US say is that when you're first starting ART, you should monitor on a quarterly basis, but that as you achieve and maintain suppressed viral load, you can have less frequent visits, so every 4 months or every 6 months. But because patients could get a card, what we heard from staff was that there was a misalignment between what was needed for the clinical care and how much the patients wanted to actually come back to get that card. And they felt that there was a conflict between the clinical needs for the participants and what the study was either what they perceived was requiring. It wasn't actually a requirement, but they received it to be that, or that the patients were driving. In opposition to that, some investigators really saw more frequent visit adherence as one of the health-related benefits, as Liz talked about before. Next slide. So these two quotes really talk about this misalignment in the first quote. So the provider is saying that, I really think there was a conflict between what the needs of the study were and what the clinical needs of my patients were. and that the patients were really driving this. As you look at the bottom quote, they say, people who would be begging us, don't schedule me for another 4 or 6 months, were now saying, please, let me come in every 3 months, because they wanted to get the $70 gift card. Next slide. The other things that the investigators and the staff talked about was really how when you have such a large-scale program that's being applied to everyone in your clinic, that there's quite a bit of logistical and administrative needs that come along with the program. You have to keep the cards secure, you need to keep track of who gets them, when they've earned them, and out. Occasionally there would be some issues with the cards working, etc. What's interesting, what we found is that even though the investigators and the staff talked a lot about these issues, having to adjust the workload in their clinic or deal with the fact that people wanted to come in more often, the patients did not perceive any logistical or implementation issues around the intervention, and certainly didn't cite it as a cause for disliking it. Next slide. So what you see here is an investigator really saying, we already have a lot to do. We have less resources than we need, and if you're going to have this kind of financial incentive system, you're really going to put the responsibilities and the requirements of that on top of a system that's already somewhat stretched. Next slide. As the investigators and staff talked about these implementation issues, though, what we really saw was a learning curve over the course of the study. They actually directly talked about that how in the beginning they were sort of figuring out how to fit this intervention in with their normal procedures, but that once they kind of got things up and running, it went quite well. Next slide. What you see at the top here is one investigator saying by the end it would just totally went seamlessly. And at the bottom, what you see is an investigator really giving credit to the women who administered the financial incentive. So as part of our study, we actually paid for a staff member to actually, oversee the program, watch the cards, give them out, etc. And a lot of the investigators talked about how you really needed that in order for this to work. The other thing I wanted to mention about this is that the parent protocol really gave a lot of flexibility to the sites, the staff, and the investigators about how to implement this program. And so they were able to make these adjustments to make things work a little more smoothly, and they talked about that in the interviews. Next slide. So the last result that we want to present here is about the end of the intervention. So as members of the protocol team who were training the staff, we really put a lot of emphasis on letting patients know that this program is not going to last forever, and as we got closer and closer to the end, to warn people it's going to end. And we were curious to see how patients and staff felt about that, and also if the message kind of got through to them. And what we found is that most patients were neutral or slightly disappointed in the fact that it ended, but reported that as patients, they didn't think that their medication-taking behavior was going to be affected. Some definitely knew that the program was going to come to an end, and others felt like it kind of was more sprung on them and wished they had been told a little more clearly about that it was going to end and when it was going to end. Next slide. So what you see at the top is a patient really expressing that they felt sad when it ended, but that they plan to continue to take their medication as they were already doing. And in the bottom quote, you see a patient who really felt like it kind of came out of nowhere, saying, "Oh, I didn't realize I wasn't going to get the incentive anymore," and said, maybe there should have been a sign or something to tell me. Next slide. The investigators and staff perceived the disappointment on the part of the patients, and while the investigators didn't think it would have much of an impact, some of the staff felt that it was. Next slide. So at the top you see an investigator saying, my patients are really adjusting very well to the lack of the incentive. But at the bottom, this person, the staff member, says not only do they perceive that their patients were sad, but they also felt that it was sad that the program was going away. And they felt that there were definitely going to be patients who were going to be not as adherent to their medication and not coming back to their visits on a regular basis. Next slide. So what did we find overall in this qualitative sub-study? First and foremost, we found that participating in this intervention made people feel good, and that really counts for both the patients, the staff, and the investigators of record. These emotional benefits were often, but not always, tied to the financial benefits, particularly for the patients receiving them, and either direct health benefits because people were coming more frequently for visits and gaining, other health other screening visits and things not even related directly to HIV, or the perceived effectiveness of the financial incentives for viral suppression really increased their acceptability, even though people didn't really know what the outcome was going to be. But these things were not as central as the emotional and financial benefits. We saw this idea of resisting the idea of paying people to do something they should always do, that they should be doing already for their health, continued to be sort of part of the conversation even at the end of the study, but that didn't really stop people from overall liking the intervention. And one of the major things we saw is that we really have to take care to balance what clinical needs are for the patients versus how often you should be giving a financial incentive. Next slide. So what would we tell future investigators or people who wanted to implement a program like this in the future? The first thing is, at least for the population in our sample, $70 was a meaningful amount of money. It definitely improved visit attendance, which we saw in the quantitative aspect and outcome of this study, but it really also had a major positive impact on morale for both the staff and the patients. Probably not unexpectedly, a large-scale financial incentive program like this is going to come with administrative and logistical challenges, and what we would suggest to people is to try to make implementation as flexible as possible so people can really fit it into whatever their normal flow at the clinic is. And to tell people the resistance to the idea of paying people to take care of themselves is going to be there, but that the people who participate are probably going to like it despite this resistance that they have, and regardless of the effectiveness. So really the bottom line is people like to get money, and they also like to give gifts. Next slide. So again, we'd like to thank Hank and Greg Davis, you, for allowing us to present these data. We want to acknowledge the NIH sponsors for this, and we want to specifically say thank you to Wafa El-Sadr and Bernie Branson, who are the chair and co-chair of our study. Recognize the rest of our qualitative sub-study analysis team. A special thanks goes to Betsy Tolley, who was a senior qualitative researcher who oversaw and helped us with this project. And then, of course, the patients, the investigators, the staff, and the study sites who made this sub-study possible. So thank you for your time and attention, and we now open it to questions either to ourselves about the sub-study or to Dr. Wafa El-Sadr about the parent study.
Hey, Teresa, this is Greg. I just wanted to go ahead and say thank you very much to you and Elizabeth for joining and presenting today, and also to Wafa. And if anyone has questions, please feel free to go ahead and ask.
So this is Hervé. Should I just jump in with a question?
Go ahead, Hervé.
Hi. Thank you so much for this wonderful presentation. I was wondering, and I apologize if this was covered and somehow I missed it, or maybe it's planned for future coverage. I know one of the things that I get a lot when we're talking about financial incentives is this notion of, intrinsic motivation, and if you give an external reward, are you shifting something that's internally driven to externally driven? And I was wondering what some observations or insights you might have had or heard from particularly the participant groups in that regard.
Yeah, that was one of the main objectives of our qualitative sub-study. We are still analyzing that data and in the process of developing a manuscript about that, so we haven't covered those themes in this presentation, but So I don't, without having that data in front of me, I don't want to
Sure.
comment on what the outcome of that is. But it's definitely an area that was very important to us to explore, and we do hope to have more information on that soon.
That's great. That's great. I will be on the lookout for it. Thank you so much.
Mm-hmm. That data has actually been quite rich, and we found a lot of we've been finding a lot of interesting correlates and sort of people really talking with mixed, saying, well, I don't really need this program, or I really like this program, but I don't need it to help me. But so, and we're going to continue to look at the data from this study to see what the impact of taking the financial incentive away is 1 year after it ends. So we're going to have a lot of things to look at with regard to what happens after it ends, and do people continue or not, as well as individual qualitative data.
And I can also say, without a doubt, just from a cursory look at the data related to those themes, that there is a very high level of internal motivation that was described or self-reported among the participants.
Did you answer that? Hi, this is Barbara Minch. Great.
Hi.
Can I ask a question?
Please, go ahead.
Okay, so I wanted to ask you how you decided on the amount that you decided on, $70, whether you ever considered a graduated amount, and whether you thought that the reason perhaps you didn't see an increase in viral suppression overall had to do with the amount.
It's a very
I guess that's speculation.
Yeah, so we had, and I'll let Wafa comment on this further, but we had a behavioral economist, people on the call might know him, his name is Dr. Kevin Volpe, help us in the design of the study. And he and I think people in his arena really feel like the amount should be very, very high. Some of the suggested amounts that were discussed at the beginning of the study were as much as $1,000 a year to really have a significant impact on anyone in the study. That would be a meaningful amount, really maybe less without regard to what your personal income is. But the reaction to that, those levels of payment was very strong from our community levels, and besides that, we got to the point where our budget couldn't support it. So there was nothing in the literature to really say this is the right number. I think at the beginning of the study, people like Kevin would have said $70 isn't going to buy you anything. Clearly it bought us visits, but you could be right that maybe it was the amount. If it had been higher, we could have gotten more people. We don't know. But there was a lot of debate back and forth, and it was, it's, I would say even today, although we can say $70 can help push up attendance, obviously it didn't have an overall effect with the viral suppression. We did see it in some subpopulations. Wafa, do you want to add to that?
Sure, yes. Thank you for the question, Barbara. I think that obviously, as was mentioned, we had extensive consultations and discussions about the amount of incentive. This took literally months. And discussions with the behavioral economists, the community, providers themselves. So this was kind of a consensus amount in terms of what people thought would be acceptable and feasible. I think in terms of what Teresa just mentioned, it's true that the behavioral economist would suggest a higher amount. However, they also very much believe in use of a lottery system rather than sort of providing the incentive to eligible participants or all patients or eligible patients. And in reflecting on the goal of our study, the goal of our study was to really try to identify an intervention that would be scalable, feasible, which means that it could be done at scale. We didn't want to, there are lots of studies that look at, it's one clinic and you can randomize to, maybe a few hundred patients to this or that. What we were trying to imagine is that if this would this have an effect if it were scaled up at a community level, which means that, it would have to be very simple, it would have to be feasible. The lottery adds complexities, obviously, would add complexities because it would require a whole infrastructure. So there were lots of factors that really we took into account in determining the amount of the financial incentive. Not just the amount, but also how it was going to be delivered and to whom. And just one other issue, as Teresa and Liz highlighted, This was financial incentives were given to everybody who was virally suppressed, whether they were suppressed at baseline or not. And some have argued that, for example, we may have seen an effect if we had provided financial incentives only to those people who were not suppressed, as an inducement, essentially, for adherence and to achieve viral suppression. However, the concern was that this could provide a perverse, kind of an incentive to become unsuppressed, and then in order to get the financial incentives when you get suppressed, you know how these things can work out that way. So I think it was also taking into account that we did not want to generate perverse incentives and do damage by having people maybe being motivated to become unsuppressed in order to get the financial incentives once they get suppressed again. So there were lots of factors that we took into account as we designed the intervention, as well as the amount of the financial incentive itself.
So, Wafa, this is a follow-up question. Did you do a subgroup analysis to look at those who are not virally suppressed at baseline to see if it did have a bigger effect?
We are looking at those now, at those kinds of data. But I also want to highlight another aspect of the study that's very unique, is that our outcomes are. This was a site randomized study. It was not individual randomization. And the outcomes of proportion suppressed was at a site level. And, and that was obtained from the HIV surveillance system, the national HIV surveillance system. And that system does not include information on whether the individual is on ART or not. So we're looking across the board at viral suppression at a site, or proportion virally suppressed at a site, knowing that people may be on ART, some people may not be on ART, and so on. So there are lots of also, complexities when you're looking at a site-level data, and also utilizing a system that, in essence, we could not disentangle the proportion who are on ART at one site versus another site, because that information is not available in the surveillance system.
This is Carl. For people that didn't suppress, was there any qualitative surveys for people that were unable to suppress, and why the intervention failed to reach them?
So again, that is a question that we're looking at in process with this medication adherence manuscript that we're looking. We've actually separated the patients out into the categories, sort of based on those 5 categories that I described at the beginning, based on ART status and viral suppression status over the course of the study, to really pull apart the different, those who had success with this and those who did not, and see what the motivators were for those different groups. So we do. I don't know. I'm not able to relay the results of that because it's in process. But that is a question that we're very interested in looking at as well.
Yeah, and that would be one of the outcomes of interest from the qualitative studies. Yeah.
This is Ken. I was just curious about the classification of large and smaller clinics. If you want to go, is that on a quartile or a tercile kind of basis, or because the number 186 seems somewhat arbitrary?
It was the if I recall correctly, it was the median.
That's right, Wafa. It was the median of the sites.
Size of the sites, yeah.
Exactly.
So it wasn't arbitrary. It was really based on the median, Ken.
Yeah, because it might be interesting to look at the upper and lower ends to see if that, even if you don't have significance, if that sort of plays out, if size matters for some of these effects.
Well, it did, Oh, you mean other than by the median? Right.
Because that's a modest effect, but it would enhance plausibility that was a real finding if the array took two extremes,
Yes, no, that's we certainly can look at that. We also looked at by type of site, as you recall, and that was looking at hospital-based sites versus community-based sites. But we did have some community sites that were quite large, so it's not exactly it's not always the case. We have some small hospital sites, so it's not a surrogate for large or small.
Yeah, but you're in the best position to look at some of these variables just because of the size of the study.
Yes, we can do that. That's a good idea. Thank you.
Studies, yeah. Okay. This is Jeff Shelton. Great presentation. Thank you so much. I had a question. Did you do any focus groups at the clinics that didn't get randomized to the financial incentives to determine how much of an effect community awareness had on which sites were providing incentives and which weren't?
So we did not do a focus group particularly to answer that question, but we did monitor that indirectly by looking at what we called migration between sites. So we looked at the volume of patient load at each site throughout the study. It was one of our monitoring criteria that our study monitoring committee looked at, and we didn't see a lot of evidence of, an increase in switching between sites. So from talking to people in general, we don't actually think that a lot of the word got out into the community. A couple times, anecdotally, somebody would call and say, oh, I got a call about the study from someone saying I heard about this, can I come be a patient? And people were allowed to switch, but they had to wait to get the incentives. They had to wait at least 3 months to become established in care before they could get the financial incentive. So I think that cut down on that movement between sites.
We did actually explore that theme within the focus groups and also within the investigator interviews. I think also in the patient interviews. We haven't formally analyzed those data, but it didn't really emerge as an issue within the qualitative data we collected.
But only at the FI site.
Only at the FI site,
yeah,
that's
only
correct,
at the FI site.
Yeah, and that was also a concern before we started the study in terms of fear that having offering financial incentives at some sites and not at others would disrupt really the services at some sites, and there'd be people flocking from one site to the other, and that's the reason why we put those safeguards safeguards in place, that you had to establish care to be able to become eligible for financial incentives. You couldn't just come one day and just get financial incentives. And in the end, I think that fear was never realized. We did not have any evidence of this kind of migration.
And just one quick follow-up question. This study conducted, I guess, around the time of the implementation of the Affordable Care Act, and in many communities there were a lot of disruptions in where where patients had to switch clinics due to provider panels and so forth. Did you have much trouble? Did you have trouble with patients who had to leave a clinic that were providing incentives because of insurance changes? And how was that handled if they went to a clinic then that wasn't part of the study?
So if they left an FI clinic and went anywhere else, when they got to the new clinic, if it was an FI clinic, they could get FIs. If it was a standard of care clinic, they got standard of care. They couldn't take the financial incentive program with them.
Yeah. So the site was randomized. Yep.
Exactly. But I would say from the migration data, we didn't see a lot of disruption, large-scale disruption between the sites because of those insurance changes.
Yeah, we didn't see that baseline, and that was also monitored along the way as the study is implemented, and we did not see any substantial movements. Yeah.
Thanks. Are there any other questions?
Would WAFA care to speculate how the results of this study might be impacted given the START results?
Well, I mean, I think it's an interesting question. I think as we were, while we were conducting the study, the guidelines did change, as you recall, and that it changed to recommending offer of ART to people at any CD4 cell count, but the level of confidence or the strength of the recommendation was not very strong at the higher CD4 count, as you know.
Agree.
Evidence was not there. I think, and that's kind of the complexity, is that we believe it is quite likely that certainly some sites, the providers may have been more likely to have offered ART to more people than other sites, and therefore this may have diluted a possible effect, for example. As I mentioned, again, reminding you that we don't know from surveillance data who is on ART and who's not on ART. So we don't know whether site A versus site B had a higher proportion on ART and therefore, more likely to garner a benefit of financial incentive than another site, that has a lower proportion of people on ART, where we wouldn't see the effect of financial incentive, since everybody had to be on ART to get a financial incentive. So now with strong recommendations for ART for everyone, that would make and hopefully providers would follow accordingly, that would make it much easier to utilize the surveillance system, because we would have a stronger sense that it's more likely that more people would be on ART now with a stronger recommendation.
Sure.
I think in a way it would help. It would help in the efforts to utilize the surveillance system to measure outcomes like viral suppression.
Thanks.
Are there any other questions for Teresa, Elizabeth, or Wafa?
This is Liza at Days. I have a question. Were there any attitudes when it came to the end of the study? You mentioned that some people felt sad about the study ending and the incentive program ending. Were there any attitudes regarding, whether this is the kind of thing that could be brought to scale? Was there the idea of either skepticism or optimism about whether this kind of program could be implemented in a long-term way outside of research?
I think some investigators probably commented on that. It wasn't a major theme that came out of it. Mostly, the attitudes and opinions related to the removal of the FI had to do with, immediately what impact it would have on the clinic or on medication adherence. But I think there was some understanding that because this was a financial incentive program, it was sort of understandable that it did not last forever. There was sort of this expectation that sort of resources and programs come to an end.
But I think going back to maybe another aspect of your question, we certainly, during the conduct of the study, I think it actually was remarkably very few issues that arose in terms of incentives themselves, in terms of impediments and bringing it to the clinic. So there were very few impediments that we heard of during the conduct of the study itself. So that's encouraging. And this was not a study, again, to remind everyone, it's not like we had massive research teams at the sites and, they were doing everything. This was really meshed into the functions of the clinics themselves. At most, we had maybe one person at the clinics, right?
Yeah.
So that it was, the whole design of the study was really trying to look at how you could potentially take this to scale. So it wasn't like research staff intensive and a lot of resources at each site. This was really designed to layer it as seamlessly as possible over the functioning of a routine clinic.
I think one thing that I would like to add to that is that for these people, these investigators at these sites, it was at scale in the sense of everyone in their clinic was participating. And when we directly asked them, would you personally do this again, they said yes. Mm-hmm. They said we need to make sure that we have someone who's dedicated to tracking it and handing them out and everything like that if you're going to do it at this level. But they said yes, and they even said yes, saying some of the people said, I don't care if it works or not. It improved our relationships and improved the visit attendance, and even if it doesn't show a marked improvement in viral suppression, I would still do it. And that we found quite interesting.
Mm-hmm. Yeah, I think these data really do show that it was feasible to implement at these sites. There were some bumps in the road, and in some cases a learning curve was needed to get to the point where it was able to be smoothly implemented. But overall, by the end of it, it was being smoothly implemented at all of the sites.
So if I could just ask one follow-up to that, it sounds like the worries about the idea that you shouldn't pay people to do things that they should do already, it sounds like those worries were dwarfed by the positive experiences that people had or the positive beliefs about the program.
Yes, that's the sense that we got. There were persistent beliefs and sort of these conflicts of concerns about, you shouldn't have to do this. But it did, the sense that we got was overall, the positive emotional benefits and financial benefits and health benefits that people actually experienced were more important than that.
And it was interesting. I mean, even some of the providers initially, as we were getting the study off the ground, some of them were really quite concerned about the potential effects of introducing this in their clinics and so on. And it was remarkable to see how they really came around,
Mm-hmm.
And when their fears were not realized, there wasn't mass migration one way or the other, and it was seamlessly implemented in their clinics, so they didn't see a disruption.
Wafa,
yes.
The guidelines are becoming more permissive in terms of the frequency of follow-up, and I'm just curious if you thought of a Gen 2 version of this, how you might consider the interaction of electronic contact with participants with, supplemented or augmented with financial incentives. So regular text messaging, like the Leicester study in Western Kenya, or another intervention that might allow for regular electronic communication with patients.
Yeah, no, I think that's very interesting. I think in a way, I do think ultimately you will need, as with everything else, we'll need to use combination interventions. And it might be interesting to combine with reminders and to combine financial incentives potentially with reminders as well. So that's kind of, you're right, the next generation is to, I think there are two, when I think about the future, like post 065 findings, I think, or can we target this intervention? We clearly did not see an overall effect by looking at, as we looked at the data, but we did see some effects, significant effects within some subsets of sites and sites with certain characteristics. So it lends us, the next question would be, is there a need to think of the next generation study that would have a more targeted approach to specific types of sites or sites with certain characteristics of patients as defined by the proportion of their patients that are suppressed or whatever. And then that could be done in combination as well with some other, or either in combination with or in comparison with, some electronic reminders and so on. That might be quite interesting to do that as well.
Hey, we are slightly past our time. If Teresa and Elizabeth and Wafa have a chance for one more question, we can ask maybe one more question.
Yes, sure. Yeah, we can do it. Yeah.
Does anyone else have any last question that they would like to ask either Teresa, Elizabeth, or Wafa?
I'll ask a last question. Hi, Wafa. This is Omar Galavraga. We met at a recent conference. Given the results and where the field seems to be right now, what do you think are the next steps in terms of trying to, where do we go next with financial incentives and viral suppression?
Yes, I think, I do think, as I mentioned just now, is that it probably, there are a couple of directions to go. One is maybe better targeting of the intervention. Who needs to get this intervention, and is there a subset of types of sites or types of individuals that would benefit from this intervention? So I think that's a very important question. So kind of targeting the who gets financial incentives. And then the second question is in combination with what? I mean, we could also try to combine with, as Ken mentioned, with reminders. So it could be reminders and rewards, for example, as a combination intervention rather than financial incentives alone. We are doing a study, but it's overseas. We're doing a study now in Swaziland where we're looking at a combination intervention. We're not measuring adherence with viral suppression because viral suppression is not available, but we're looking at retention, and there we're using, again, what we're calling a combination of reminders and rewards, using SMS, but also providing some rewards, i.e. financial incentives, to look at both linkage and retention. So I think, and other rewards. So I think people are now, the next step is really how to target this better, how to measure the outcome in a simple way, and lastly, combined with something else as well that could enhance the effect.
Thank you.
Thank you very much, Wafa. Well, with that, I would like to thank everyone who joined us today, and I hope you're able to join us for the next one. And again, thanks so much to Teresa, Elizabeth, and Wafa.
Thank you all. Have a good day.
All right.
Bye.
Everyone have a great day. Thank you. Bye.